So we move on to our next session. And for this session, it's my honor and privilege to invite Professor Dr. Tejas Patel, Dr. Vishal Sharma, and Dr. Joel Shah, and the moderators Parminder Singh, Dr. Tushar Nikam, and Dr. Prakesh Vajirani. But when Dr. Tejas Patel is there, I think nobody else should be speaking. I think with the core of my heart, from the bottom of my heart, I have very high regards for Sir. Sir is one of the pioneers of multiple things. And I always tell him that, sir, I respect your vision. When people were looking at femorals, you were looking at radials. And when people have started learning radials, sir is looking at robots. And when I tell this to him, sir, I appreciate your vision, he jokingly tells Kamal, I wear the glasses. I don't have the vision. But sir, I hats off to you, and a pleasure to have you, sir. On speakers for the session is going to be Dr. Prashant Vajirani. He's an interventional cardiologist with teaching experience at Ujjain, and he has been trained in complex PCI at Tokyo in Japan with Mr. Hamazaki in Japan for a short duration, also with the Terremote training session, and he's been reviewer for multiple journals. Our next speaker, who's going to talk about IVUS, and the other person who's debating against us is no smaller a demigod. Next slide, we have Dr. N.K. Mahesh. He's been there with us for 3 years now in succession. Dr. Mahesh, thank you for being with us always. And it's always a pleasure, though he's been talking about different things a lot of times, but I believe OCT is talking for the second time. So pleasure to have him. He's a head of the department, Apollo Adlux Hospital, observer at Mount Sinai, member of CSI, of course, and fellow of American and European Society of Cardiology. Next slide. And I would hand over the session to Dr. Tejas Patel and all the chairpersons and and the referees and the scorers. Over to you for the case. Can you go back, please? Can you go back, please, for the case? So this is the case, 66-year-old male NSTEMI, in-stent restenosis, osteo-proximal RCA 4/28 implanted 8 months back, eGFR 44, preferred mode of imaging. Over to you, sir.
Yeah, Kamal, I think let us hear both the speakers, and we will have ample time to discuss pros and cons of both the imaging technology. I'm using both the technologies nowadays, left, right, and center. OCT, in fact, I learned OCT first, and on the basis of my understanding of OCT, I have learned high definition IVUS. And in our lab, almost 35–40% of the cases are image guided. So I will like both the speakers to present their cases, and then we can have good informal discussion. Yes.
Over to you, Prashant.
Thank you, sir. So we'll begin with the session. So dissection of the details given. So we have a osteo-proximal RCA, and the previous stent was a 4 mm stent. So it is a large vessel diameter, and it is an early stent failure because the patient has come back with ISR within 8 months, and he has a renal insufficiency of GFR 44, which is stage 3B. So what more do you want to know now? For the patient, like patient factors are whether he's a diabetic, whether he has other comorbidities, whether a stent which was placed in the previous event, whether it was a stable event or it was an ACS, whether he's a drug defaulter, whether he was on DAPT, which one, statins, and whether imaging was used in the previous procedure, whether malapposition was there under expansion, what was his MSA at that time, whether there was plaque burden at the stent edges, and calcium, and etc. So why do I want to know all these patient procedure and lesion factors? Because all of these will ultimately lead to the ISR. So when we are talking about ISR in the drug-eluting stent era, according to the ARC Academic Research Consortium definition, they have still not included or updated OCT in the definition. But nevertheless, whenever you are using IVUS or OCT, your minimal cross-sectional area according to the definition should be less than 4 mm square, and in LM should be less than 6 mm square. So we all use this reporting for ISR by the Mehran classification, but this is mainly done for the BMS stent, which Dr. Mehran has invented. And now when we have got a visor, we have to report it by the Wexman's ISR classification. And because now we come to know about the mechanical and the biological causes. Mechanical like the stent under expansion and the stent fractures, and biological like the neointimal hyperplasia and the neoatherosclerosis. So why it is important to differentiate these causes? Because we know that early stent failure will be more of mechanical, while late stent failures might be because of more of the neoatherosclerosis. So whenever we are approaching a stent failure patient in 2022, two things are most important. One is imaging, And second is one of these fancy items you should be having in your cath lab, which is either a scoring or a cutting balloon, or at least an NC balloon or a drug eluting balloon, the DCB, and other things like a rota or a laser. Because this is how, depending upon what you have found out on imaging, what you have, like, do you have a underexpanded stent, malapose stent, or do you have NIH, do you have neoatherosclerosis, you will need one of these fancy balloons, and without which you will not be able to do justice to your patient. So now what do you want to know more with the imaging? We all in our first year cardiology were taught this Glagos phenomena, in which in the atherosclerotic vessel, this external elastic membrane expands, and this is what is called the positive remodeling of the vessel wall, and this can be made out only by the IVUS because of this greater depth penetration. So because of which the stent might have been under expanded. We also want to know about the plaque volume, the morphology, the residual plaque burden at the edges, whether there was any stent fractures or calcifications. So if I want you to compare the OCT and the IVUS images, you can make out the HD IVUS images of the external elastic membrane is more clearly discernible by the HD IVUS only, and whether OCT cannot be doing justice by making you know the EEM, because there is no penetration with the OCT. And because of this greater EEM delineation by IVUS, you will have greater lumen areas ultimately by IVUS. And you would have seen in the past that histological image is same as OCT comparing to histopathological image. But now HD IVUS will also give you the same images, because apart from the EEM demarcation, the fibrofatty, the lipid core is very much visible by IVUS and not by OCT, because because of the OCT signals, they get strongly attenuated by the lipids. If you make out this, we have all done plasties to such lipid-rich, atheromatous, necrotic core patients, and in which you'll see this OCT, you're almost blinded because of so much lipid. Whereas in IVUS, you'll be able to differentiate them, and you'll make out the correct EEM and make out greater lumen areas. So why is this happening? Because IVUS has a greater depth penetration with no need for any luminal blood clearance. And also, when you are using IVUS in a patient of an osteal lesion, then OCT will not help you much. And also for adequate plaque burden and characterization, then IVUS is preferred. So if you want to do a correct sizing of the vessel, sizing of the lumen, IVUS scores over. Adequate assessment of plaque distribution and characterization, again IVUS has plus points. And if it is a osteal location, renal dysfunction, CHF, and live real time can be done only with IVUS. So similar to our today's patient's case, this patient had an LED ISR and LED implanted, and then after 10 months, he came back with an ISR, and when IVUS was done, you can see the distal reference in the normal vessel was 6.8 millimeters square on IVUS, and his in-stent CSA was 3 millimeters square. So that is, vessel diameter is almost double the stent diameter. Now, why has this happened? Because this is the under expanded stent. As you can see, there is no stent malapposition. Stent malapposition, stent under expansion are two different things. So here the stent is well opposed, but it is under expanded. This has happened because the EEM has not been taken into account. So visualization of the EEM with IVUS enables one to acquire a larger MSA compared with OCT. And this, as I discussed, why this is happening, because of greater soft tissue penetration and blood penetration, which is not there with OCT. OCT has excellent surface detail. The macrophages can be seen only with the OCT, but not with the IVUS. So you can see this very crisp images. If you see this A image, very crisp images of HD IVUS, where you can differentiate exactly the intima, the media, the adventitia, which was not very well initially with the other IVUS before the non-HD IVUS. And if you see this, the stent stress, the stent malapposition, calcium, was all very crisp images now seen with HD IVUS. And if you see this image C, the same thing, the fibrofatty thing, which is seen on media, is not very clearly seen on the OCT. This is because superior tissue penetration of IVUS permits full vessel evaluation through the fibrous and lipid plaque, whereas OCT signals are attenuated by lipid. So gone are the days when people used to say that you cannot measure your thin fibrous cap on IVUS. Now you can measure with HD IVUS. You can even measure your thin cap fibrous, and you can also make out the exact extent of your lipid necrotic core and your EM on the HD IVUS. So we discussed this, the exact extent of the plaque burden can be made out. And these are images on the Philips machine. This is not even HD IVUS, this image stent malapposition, and this is the intimal dissection. And this is now the chromophore technology, where when you have a stent which is malapposed, you will be able to see the blood RBCs which are going underneath, and you can make it out easier. So same histological pictures you can even make out now on HD IVUS. This is neoatherosclerosis, which is made out on the IVUS. The same thing on the histopathology, and the same thing which is made out on the OCT. So HDIOS is now no less than the OCT also. And stent malapposition, previously it was difficult, now it is very easier to make it out. And gone are the days when people used to say that now you cannot make out calcium nodules cannot be made out on HDIOS. All forms of calcium, whether superficial, deep, calcium plaques, nodules can be made out on HDIOS. And you can also even grade them. You can even make out the arcs, and the different gradings which are available for calcium can be done on the HDIOS. So for correct vessel and vessel diameter and correct plaque length and assessment, HDIOS should be used. So now coming to IOS or OCT. So for better resolution and intimate surface details, the OCT will be favored. Whether for better penetration and correct vessel sizing, IOS will be favored. So for plaque volume, morphology, residual plaque burden, and stent edges and vessel sizing, IOS has more points. Stent under expansion, MSA, IOS has more points. It is calcification, stent fractures, malapposition, macrophages, of course, OCT will be favored. And when there is an osteo-proximal lesion, a large vessel, and impaired renal function, then IOS will be favored. So impaired renal function, I'm sure my speaker will tell more about saline OCT, but in this patient is not a patient for saline OCT because it is a complete no-no for big proximal vessels, ostial and left maze, while saline OCTs can be done for calcific milieu and small vessels. And you can also use colloids in patients who have a low GFR, but they are also not renal friendly. Availability is one issue, but they also have many anaphylactoid reactions. So is there any head-to-head trial evidence with IOS and OCT? So multiple trials which were done, and one is a 70 small trial by Habara et al, which showed that the OCT guidance for stent implantation was associated with smaller stent expansion and more frequent significant residual reference segment stenosis as compared to IOS. But it was a small study, 70 patient, which showed a greater stent expansion and smaller stent edge plaque burden with IOS as compared to OCT. So another trial, opinion trial, it showed that OCT had a smaller MSA after PCI with a numerically smaller mean stent expansion index than the IOS, and of course lesser contrast used in IOS. But on follow-up at 8 to 10 month study, they also found a lower incidence of uncovered strut in IOS guided PCI than the OCT group. So the same thing was found in the OPUS class study, that the higher MSAs were seen in patients who were IOS guided rather than OCT. So ultimate summary was that the bigger the better concept, that 1 millimeter increase in the MSA is associated with 20% decrease in ISR. So the long-term outcome ultimately depends more on the result which you achieved rather than the device which you used. So there has also been one study of OCT as compared to angioscopy, not angiography, but angioscopy, where I would like to highlight that 18 OCT guided, where it classified that these are non-lipid plaques. Actually on angioscopy, they were all yellow plaques and white plaques and thrombus and ruptured plaques. So in this, it was found that OCT analysis was underestimating instability of in-stent restenotic lesions. So my concerns for OCT use in this patient, ISR in a large vessel, ostial location, it was an aorta ostial where the coverage of the exact ostium was not done. So where OCT will not be much useful. Also, we need to look for the EM, the positive remodeling, and the correct vessel sizing. And it is impossible with just saline OCT to get good blood clearance, because all we'll get is a blood vulse. Some amount of contrast will be required for a good clearance, and with an impaired GFR, it is unfavorable in the era of zero contrast IOS guided PCI. Also, plaque morphology and volume assessment at edges will have to be looked for. So for these reasons, IOS will be scoring over. Also, if you go to the OCT information on the manufacturer side, they intend that OCT is used to use for only for up to 3.5 millimeter vessel, but we also use it up to 4 millimeters. So the take home is, whenever you want surface analysis for plaque prolapse, tissue prolapse, more visible dissections, thrombus, macrophages, then OCT has more points. And when you want depth analysis, sizing, fibrofatty plaques, lipid-rich plaques, large coronaries more than 4 mm, LMs, LV dysfunction, then IOS has more points. So, but if you have a cath lab visitor and want to show off your fancy new rich toy, then you can show them this 3D orientation with the OCT, or now you also have this colorful imaging of virtual histology IOS, which is available. So in conclusion, HD IOS identifies all histopathological stages of atherosclerosis, including your thin-capped plaque and all the mechanical and biological causes of stent failure, which we discussed. And HD IOS, due to better depth penetration, has an edge over OCT in estimating correct vessel size and acquire larger MSA. HD IOS is real-time, live, without any need for blood clearance, unlike OCT. OCT will need some contrast, even if saline run style, which is usually not possible in large proximal vessels and predominantly ostial, without which you'll just get blood swells. So early stent failures, HDIVS is preferable, while in late stent failures, OCT might have an edge. Thank you.
So, yeah, you can start your talk, Dr. Mahesh, and once it is over, we will discuss it out, everything.
I thank Dr. Kamal Sharma for this opportunity. It's been 3rd year in a row. Dr. Tejas Patel, sir, big fan, big admirer. We really appreciate your innovative ways of handling interventional cardiology. And I'd like to quote your statement, which says that I'm just an angioplastic. So I just have no theory to say. Prashant has done all the job that is done to be done. So I will just show the case and a few slides to show the differences. That's all. Greetings from the Parimala Heart Institute. It's a multicentric heart institute in a small village. So we have all these modes which Dr. Prashant was trying to say. I can have a tissue mode. I can have a lumen mode. I can have a stent-only mode, which will tell me where all the problems. I can also have a fly-through mode. Although they appeared fancy to you, they have an immense amount of information if used correctly. So in addition to that, I have angio co-registration. Angio co-registration is very, very important, specifically when you would like to find out areas of underdilatation, areas of where the stents are not covered properly. So angio co-registration is a big advantage. And in addition to that, this is the way in which the angio co-registration shows you the red plaques where the areas are not opposed well. And see the amount of techniques I have to find out whether there is the stent is opposed well. I have an apposition indication bar. The red ones show you're in trouble more than 300 microns. I have an L mode. I have a stent road map that you can see here. And I've also got a dissection, cross-sectional view where you can see the red dots there. So if this OCT was done previous to in the original case of the case we're discussing, probably we would not have discussed this case. And if it was deployed properly, it wouldn't have happened. So now see the possibilities. Although there is 1, 2, 3, 4, it is basically neo-intimal hyperplasia, neo-atherosclerosis, and stent expansion. Whatever you do, as Dr. Prashant was saying, IVUS is no less than OCT. That means IVUS is actually not as great as OCT. It is clear from this histopathology and OCT comparisons, homogeneous, bright, uniform layer, heterogeneous composition with in-stent necrotic growth. Everything that you see histopathology can practically be seen in this IVUS image. And stent under expansion requires no great shakes. But the cause of an ISR is invariably a combination of these, and it is not that it's purely neo-intimal hyperplasia or purely stent under expansion. I don't have a proximal RCA ISR, so I'll show you a proximal RCA disease, which I have imaged with this thing. You can see it's a huge vessel. It's a 4 millimeter vessel. I actually ended up putting a 4 millimeter stent in this vessel. This is pre-dilation. The vessel has been pre-dilated. After the pre-dilatation of the distal segment also, we got a flow through this. And then I did the first pre-run OCT, pre-run RCA proximal. Now you can see what is the information that you require, what is the type of the plaque that you have. It is predominantly fibrous. What is the amount of calcium you have? Little to none, very less calcium. And there is, you can see that there is a fibrous plaque. So all the information that you want on the about the vessel is available from here. It tells you about the diameters, maximum distally being 2.82, 2.33, in the mid 2.24, 2.45, 1.05, this is the tightest area, and 1.76. This is the dimensions that you wanted. Area has been given to you, and then you do a post dilatation and you deploy a stent. This time I've used actually BBS or BRS, whatever they're called. It's a scaffold. Post scaffold, you deploy post dialysis, and this is the final image. Now I'll show you the images of the post pullback after the image. Now you can see that the whole area can be seen as clearly as you want to see. You can see there is no stent malapposition. The vessel is absolutely clearly seen, and this is the post pullback cross section to make it very clear. This is the only thing that you don't see when you do a saline OCT. That is red, the small dots will be there, but that does not disable you from identifying what is the type of lesion and the opposition of the stents. So post pullback, you can get a 3D reconstruction to show. And then you can see at OCT pullback, the one so-called fancy OCT pullback. This is an OCT 3D pullback of a MERS where you don't see any stent struts anymore. And this is our final area. So how do I calculate the final area? Distal maximum 3.74. The stent opposition is very good. You can see the stent struts. And this is maximum 4.11 millimeter. Please, diameter is 4 millimeters. And I have shown you very clearly all the layers are in this OCT image. This is 4.59 millimeter diameter. And the surface area can be done. All this was done by saline. So this is the first article that I published in Indian Heart Journal, study of saline optical coherence tomography guided percutaneous invention. This was the first article. This was a pilot study, and that showed, these are the images we got from this pilot study, which shows at TCFA, calcium nodule, calcium dissection, everything can be seen. Double layered stent, ISR, red thrombus, cholesterol crystal, all the works. And this is how a saline OCT pullback looks like. There is no contrast. So saline was safe and effective as a flush media for coronary FD OCT. Following which, questions arose as to, okay, what happens to the dimensions of the vessel? What happens to the exact length of the lesion for when you do a saline versus a contrast OCT? So we brought out the second article, saline as an alternative to radio contrast for optical coherence tomographic guided percutaneous invention, a prospective comparison, where we compared in 26 runs, contrast 13 and saline 13, MLA, proximal reference area, distal reference area, and percentage of area stenosis. So all the factors were combined. And this is one of the pictures from the presentation we find. You will not find hardly any difference in the OCT and the contrast. Unless I tell you this is OCT, this is contrast, and this is saline, we may not be able to differentiate. And in this study, it was proven that there is using heparinized saline as a flushing media for coronary FD OCT may result in vessel dimensions that are comparable with contrast. Heparinized saline may be used as a contrast, saving alternate for FD OCT during PCO optimization. So that take-home message was saline OCT is feasible and safe. All morphologies can be seen. Saline does not significantly affect the measured parameters of this PCI. So in this case, I would say where I have shown you a 4.5 millimeter vessel OCT done with saline proximal RCA, the same thing can be applied to this case, and all the parameters which should tell you whatever is the type of the lesion that led to the ISR, what is the result of the cutting balloon on the ISR, what is the result of the stenting on the ISR, can easily be defined and clearly shown with OCT. Only thing is that angio co-registration with saline is still lacking, in which case you have to use 1:1 saline and contrast. So thank you. Here I rest my case.
Thank you, both the speakers. Yeah, so both the speakers have put their case very strongly. My understanding of imaging says that first thing is whatever you are comfortable with and whatever your eyes are comfortable with to see and interpret properly for your patient is a good modality for you. Both modalities have their pluses and minuses, I agree. Because we have explored OCT too much, and nowadays we are significantly exploring high definition IVUS. One thing I will like to tell that like OCT cannot be done in left main. That is what is the Western recommendation by and large. But 95% of the Indian left mains are perfect for OCT evaluation. And actually, we have now almost 90 cases of left main bifurcation done with OCT evaluation, and we are going to publish with the follow-up. So, because our left mains are never more than 5, and 5 is good enough if you inject well, and it will be seen. Only problem is the ostial left main is a problem, and sometimes when you have a contrast issue, when you want to really restrict your contrast, then it is a bit of problem. As far as high definition IVUS is concerned, I have started liking that modality also, And I don't know how I'm going to, use both the technologies in the best interest of my patient. I will simply give you one example. Today itself,
I think we have connection issues with any other panel members, Dr. Vishal, Dr. Joel, Parminder, Dr. Anand.
I would like to just ask the speakers that what is their percentage of use of both the images in their contemporary practice? How frequently do you use IVUS or OCT, sir, in your practice? So I think.
So I have the HD IVUS of Philips with the Angio co-registration, which is a fabulous thing. So that gives me Angio co-registration as well as the pressure wire co-registration. The co-registration of the Philips HD IVUS is what I am now looking at. I'm just learning how to do things properly. I'm not an expert yet, but my go-to imaging still happens to be OCT. Since I am not an expert at the IVUS so far, it will be about 80-20. And I do imaging in about 30 to 35% of my cases.
Prashant, of late, how many times you're doing IVUS?
So we are doing only IVUS at present. We don't have the OCT, although we had done OCT in between when we were trying to sort out which one to buy for the hospital. So now we are doing HD IVUS almost daily. We are doing it, and also we are also reusing it. So up to 5 times we are just ETOing it and then using, and we are getting.
Vishal has access to both. So Vishal, what do you use more?
I think as far as the cost issues are concerned, I think IVUS scores over OCT, frankly speaking, at institution level. But yes, as Sir said, Tejas Sir said, nowadays leftmen also, especially the Indian leftmen, they are well visible OCT. I think imaging-wise, OCT scores over IVUS as far as characterization and the clarity is concerned. It also depends upon the user's preference or what he uses and what he's familiar with, as Tejas Sir said. So I think that depends on the familiarity. There are some cost issues. Otherwise, both have, I think, equal scores as far as the imaging and the results are concerned.
Is Dr. Joel?
Dr. Joel, unmute, please.
Yeah, of late we are started using OCTs. Previously we were only doing IVUS. But as Tejas Sir said, I would agree with Tejas Sir that whichever modality you are comfortable and whichever with modality you give good result, you should use that. There are certain aspects, as Sir said, ostial left main and their OCT has some issues. But if you go with ostial LED circle lesions, bifurcation LED lesions, OCT images are much more better. So whichever mode is comfortable, I think we should go for it. And regarding the renal issues, nowadays, lesser contrast and with saline, we can always get good images with OCTs.
So can we conclude? So it is 1 minute, 2 minutes early, we can conclude.
Yeah, I think we had a wonderful session. Thank you, both the speakers, Dr. K. Mahesh and Dr. Prashant. Thank you, Chair. I think Dr. Tejas is here. We can hear from him. Sir, are we audible? Sir, yes, sir. I think you have connected back. Sir, please unmute. We can see you now.
Sorry for the interruption on
yes,
our
sir, no issues, sir. We were just taking the take-home message, and you are right at the time of giving the take-home message, sir.
So,
please, sir, go ahead.
Yeah. So, because of the time constraint, I will not be discussing the thing what I was supposed to discuss. But I personally feel that as far as the tissue characterization part is concerned, OCT scores over high definition IVUS even today. Now, Angio co-registration was previously only with OCT, but in our lab, like we have Angio co-registration available for both IVUS as well as OCT. So that is almost equal. Secondly, looking at intramural hematoma, subintimal hematoma, and even the smaller dissections and small strand fracture and all those things, I think definitely high definition IVUS plays a great role. And there are good number of patients when you want to finish your stenting in 20-25 cc's of busy pack. where you have no choice. Like a patient who has anterior wall MI who presents with you, a little late and still symptomatic and has acute renal shutdown.
This has gone off again.
Yeah. Okay. We move to next session. Thank you very much. Thank you, everyone. Thank you, chairpersons, speakers. Bye-bye.